Hello all, this is an exciting morning at ACC 2017 in Washington DC. My name is Wale Parikh, I'm one of the EP fellow at University of Kansas, and today I am with Dr. Bunch. He's an EP attending at Intermountain Healthcare System, and I'm going to ask him a few questions about ACC 2017. Good morning.
Good morning.
Welcome. First question, I want to ask you about your study which you just presented. Can you tell us more about that?
Yeah. Um, yes. So we're specifically interested in low-risk atrial fibrillation patients. As you know, guidelines are changing as to how to treat them. The Europeans have completely removed any indication for aspirin. The American Heart and ACC guidelines are, I believe, under construction, but continue to have an indication for aspirin. And that was really not supported by many trials. The SPAF trial was the only one that was positive, and it had some methodology that was flawed. So we wanted to specifically look into our system, a community-based system. What's the role of of antithrombotic therapies, whether it's aspirin, Plavix, warfarin, or warfarin, an antiplatelet agent, and what were the outcomes? And what was very interesting is the patients, and these are patients with a CHAD score of 0 or 1 or a CHADS VASC of 0 to 2. And across all groups, we saw that those patients that had no therapy had the lowest risk of stroke and TIA, lowest risk of bleeding. Those patients that were on antiplatelet agents, aspirin Plavix or aspirin warfarin had the highest rates of bleeding and kind of and stroke. And in an intermediate group were those patients on warfarin. So clearly antiplatelets were not providing benefit, but were actually exposing the patients to harm, not only from the indication of what they were there for to prevent stroke. There was more strokes, but we're also seeing much more bleeding. I was just speaking with Dr. John Cam, who is the chairman of this session, and he was saying they're seeing the same thing worldwide, that these antiplatelet agents increase bleeding without giving any benefit. So I suspect the ACC and American Heart will ultimately follow the ESC and the American ATS Society in removing aspirin as a therapy to prevent stroke.
Again, my understanding is this is about clinical strokes. So, what about asymptomatic emboli and dementia?
Yeah, absolutely. This is a registry study, so it was based on strokes defined based on a neurologic diagnosis, and we like to correlate with a radiographic, trying to minimize mischaracterization. So I have a lot of interest in dementia, and we found that about 7 years ago that atrial fibrillation was associated with all forms of dementia, including Alzheimer's disease. And subsequent studies have confirmed that, some of which have shown that looking at histology from the Mayo Clinic Alzheimer's data set, that what we're missing is little small embolic strokes or small bleeds. So the subclinical events are critical. And we found that there's a few things that are critical with our atrial fibrillation patients. One is a delay in anticoagulation. Those that should be treated and we wait, that raises risk of dementia. And we'll present that at Heart Rhythm in 2 months. The other is warfarin use that is volatile or poor time in therapeutic range. But the other one that we found that's been quite interesting is that patients that are on an antiplatelet and are over anticoagulated have very high rates of dementia on the scale of about 3% a year. So we're seeing some of these major breaking trials to reduce, unstable angina at 2% over 3-4 years, but here we see in our patients with atrial fibrillation, over anticoagulation can lead to cognitive injury on very high levels. So we really have to be careful with what anticoagulant we use, if we're using it correctly, and if they really need aspirin. And aspirin really should only be considered if there's an ischemic indication that's pervasive. And then we recently published in the American Heart Journal or the American Journal of Cardiology, that patients on DOACs or these novel agents tend to have stroke rates similar to the trials in the community, but dementia rates are extremely low, in particular with the agent dabigatran. Even though we had the longest follow-up with that, we're seeing the smallest incident of dementia for reasons we're trying to look into that we don't fully know at this time.
That's interesting. Now, on a separate note, you serve as an editor of one of the big journals, Wanted to ask what will be your tips for the fellows of attending conferences like ACC 2017 and other big conferences, and how we can utilize this for networking purposes?
Oh yeah, I would be involved. I think electrophysiology is a small community, and we share the same passions. And I think you find rich colleagues here that that become lifetime friends. Like your mentor, DJ Lackey-Reddy, has become a close friend, and we met each other, I think, at American Heart 8-9 years ago. Um, I think I learned a few things from conferences, and as a fellow, you get the opportunity to submit an abstract and present it. But if you think about it, creating the presentation, whether it's a poster or an oral presentation, you really have done the manuscript. And so if you go through the effort to do the presentation, you've almost completed the manuscript. So I think for fellows, they should take that and just finish the manuscript, finish the process, and get it submitted. There's a number of journals that are interested in those things. Heart Rhythm Journal would love more basic research, more translational research. Heart Rhythm Case Report is the journal I oversee is very interested in these case series that people present and these interesting cases, and we don't see as many as I'd like to see. They're in sessions at these conferences. They garner a lot of interest. They're educational, but then I don't quite see them all come to us, and I'd like to see that.
Thank you. Thank you, Dr. Bunch, for your valuable advice.
No, thank you.
This is Wale from ACC 2017. Keep looking for more videos on our blog at YouTube, Fits on the Go. Thank you.